I'm thrilled to present you the topic pneumonia, current clinical guidelines, diagnosis, therapy, and management in 2025 today. This presentation is based on the latest insights from Internal Medicine 2025. My goal is to provide you with a comprehensive overview from diagnosis to therapy to ethical considerations. Whenever you're a specialist or a medical professional, I hope you'll take away valuable insights. We'll be using the newest studies, the newest technology. This will take around 15 to 20 minutes, so grab a coffee and let's get started. Why is pneumonia so important? Globally, it's one of the leading causes of death, and in Germany, about 20% of hospitalized patients are affected, compared to just 4 to 12% for ST elevation myocardial infarction. Hospital-acquired pneumonias account for 26% of infections contracted in hospitals, a major challenge. These numbers highlight the severity of the issue, especially for older and immunocompromised patients. Add to the longer hospital stays and rising costs, increasing antibiotic resistance doesn't make things easier. We'll cover that later. Let's look at how we classify pneumonias. Pneumonias can be divided into three main categories. The so-called pneumonia triad. Community-acquired pneumonias, or CAP, acquires outside the hospital, often caused by Streptococcus pneumonia. Hospital-acquired pneumonia, or HAP, develops during a hospital stay, frequently involving multi-drug resistant pathogens like Pseudomonas aeruginosa. Then there are pneumonias in severely immunocompromised patients, where opportunistic pathogens like Pneumocystis jirovecii dominate. Here you can see the most common pathogens. Knowing them helps us act targetedly. Each category requires its own strategy, so stay tuned. If you have any questions, write them down. I will make another video if I don't know the answer right now. Let's look at what causes pneumonia and who is at risk. For CAP, Streptococcus pneumonia is the main culprit, while HAP often involves Pseudomonas or MRSA. Immunocompromised patients face Aspergillus or viruses like CMV. Risk factors include long-term steroid therapy over 20 milligrams for more than 4 weeks, COPD, malnutrition, or severe infections like influenza or SARS-CoV-2. Burns or diabetes also play a role. These factors not only increase risk but complicate therapy. This shows how crucial a thorough patient history is. So let's move to diagnostics. Diagnostics start with a solid history and examination. Ask about fever, cough, productive or not, shortness of breath, chest pains. Inquire about pre-existing conditions like COPD, diabetes, travel history. Think Legionella from air conditioning, and medications like immunosuppressants. During the exam, look for rapid breathing, cyanosis or crackles on auscultation, and a dull percussion sound with infiltrates. A thorough history is the first step. Many of you know this from practice, so let's complete this with lab tests. These are the lab tests used in pneumonia diagnosis, their purpose, and what results you typically expect. CBC, CRP, procalcitonin, sputum, blood cultures, arterial blood gas, PCR, urinary antigens, serology, pleural fluid analysis, and you can see in the table what exactly do we use it for and what you can see exactly with these tests. Additionally, there are a couple of more laboratory tests in pneumonia we can use. For example, lactate, electrolytes, renal function, liver function, glucose, HIV tests, cytology of pleural fluid, and BAL, or bronchoalveolar lavage. Good. Ready for imaging? Imaging is essential. Chest X-rays show infiltrates often left basal in CAP. For example, for complex cases, ACT helps identify complications like abscesses or the tree in bud pattern. Ultrasound detects pleural effusion, ideal for planning a puncture. These methods confirm the diagnosis and track progress. Here you can see imaging modalities used to diagnose pneumonia, their purpose, and the typical findings you can expect. The most used is chest X-ray, chest CT, lung ultrasound, lateral decubitus X-ray, and MRI. The chest X-ray is the first-line imaging to confirm clinical suspicion of pneumonia. Chest CT is more detailed evaluation used when X-ray is inconclusive or complications are suspected. Lung ultrasound, bedside tool used in ICU and in patients where X-ray is impractical. The lateral decubitus X-ray to assess mobility of pleural effusion, and MRI occasionally in children or if the CT is contraindicated. Now, microbiology. Microbiology provides clarity. Take 2 blood cultures before antibiotics, positive in 5 to 15% of CAP cases. Sputum cultures help with productive cough, and multiplex PCR detects atypical pathogens like Legionella with 75% sensitivity. Urine tests also for pneumococcal and Legionella antigens are quick, up to 72% sensitivity for Legionella. For immunocompromised patients, bronchoalveolar lavage, or BAL, is ideal for pneumocystis. It's about finding the right pathogen. Here's also a table with all the microbiological diagnostics in pneumonia, what the purpose is, typical finds, and some more information about it. Most used is sputum grain stain, sputum culture, blood culture, urinary antigen tests, PCR, pleural fluid culture, serologic tests, fungal tests, and more. Severity assessment is critical. We monitor neutrophils below 1000 per microliter is concerning, as well as HIV or transplant history. Stability means heart rate under 100, respiratory rate under 24, blood pressure over 90, temperature below 37.8 degrees Celsius, and oxygen above 60 millimeters mercury. Scoring systems like CURB 65, that means age over 65, confusion, respiratory rate over 30, low blood pressure, or you can use SOFA to guide us. Severe cases need intensive care. Now let's go and look at the therapy. For CAP, we tailor therapy. Low-risk patients go home with amoxicillin. Severe cases get inpatient ampicillin and sulbactam. With comorbidities or poor prognosis, palliative care may be needed. Therapy lasts 5 to 7 days, longer for complications, of course. It's about individualizing treatment. Now let's see some details. Antibiotics are the key. Outpatient CAP gets our amoxicillin. Inpatient cases receive amoxicillin and sulbactam or a third-generation cephalosporin. Atypical pathogens like Legionella requires macrolides or fluoroquinolones. For penicillin allergies, we switch to alternatives. Severe CAP may need beta-lactaman or macrolide combination. It's about precision. Immunocompromised patients need special care. Use urine antigen tests, blood cultures, and PCR for viruses like CMV. BAL or bronchoalveolar lavage is ideal for pneumocystis or fungi. Teamwork is the key here. Consult infectious disease specialists. For those patients, cotrimoxazole for pneumocystis has an 85% success rate, and voriconazole works for aspergillus. Viruses are treated with oseltamivir or remdesivir, and we start with broad-spectrum antibiotics. Therapy lasts 14 to 21 days, monitoring kidney function, which is very, very important and crucial. HEP is a little bit trickier. Blood cultures catch 20 to 30% of cases, and tracheal secretions are key in ventilated patients. Bad news, antibiotic resistance is a growing threat. MRO therapy starts 24 hours before hospitalization, 5 days for gram-negative pathogens. Pseudomonas is treated with piperacillin and tazobactam, MRSA with vancomycin. Isolation and hygiene prevent spread, a challenge we must tackle together. Reevaluation is also critical. Check for stability criteria like heart rate, breathing, oxygen after 48 to 72 hours. Therapy ends after 5 to 21 days, depending on the progress. Monitoring with lab tests, CT for persistent symptoms, and it's all about timing and precision. Also, prevention is the most important here. It saves lives. Vaccinate against pneumococcus and influenza, promote smoking stopping and hygiene, long-term test lung function and follow-up, especially with immunocompromised patients. Educating patients about early symptoms is the key. Now let's open our trusted friend Orbis and see a medical case. 38 years old with fever, shortness of breath, lab tests showed high leukocytes, and the X-ray revealed a left basal infiltrate. We started with ampicillin sulbactam and he improved in 5 days. This shows the importance of early diagnostics and teamwork. Patient named TH, 64 years old male with medical history of type 2 diabetes, chronic obstructive pulmonary disease, chronic corticosteroid therapy, prednisolone for 10 milligrams a day, and history of smoking 40 pack years. Comes with productive cough, high fever, 39.2 degrees Celsius, and dyspnea for 3 days. Vital signs show RR 28 per minute, HR 108 BPM, BP 102/64, and SpO2 87% on room air. Temperature 39.2 degrees. Physical exam shows dullness to percussion at the right lower lobe, crackles and decreased breath sounds, mild confusion, suggestive of hypoxia and or sepsis. These are the initial investigations. We did CBC, CPR, procalcitonin, ABG, urea, creatinine, and lactate. Here are the results and the interpretation. Imaging. What did we do for imaging? Chest X-ray at first, chest CT, and lung ultrasound. Chest X-ray shows dense consolidation on the right lower lobe with possible pleural effusion. These are the findings of chest CT and lung ultrasound. Microbiology. What did the sputum grain stain show? Numerous gram-positive cocci in chains. Sputum cultures shows pneumococcus pneumonia that's penicillin sensitive, which is amazing. These are the next investigations we did and the results. And the diagnosis is severe community-acquired pneumonia with right-sided empyema due to Streptococcus pneumonia in an immunocompromised patient with diabetes and steroid use, with acute hypoxemic respiratory failure and sepsis. How do we manage that? Hospitalized in ICU, empiric antibiotics with ceftriaxone, azithromycin, switched on high dose of penicillin G after culture results, oxygen therapy, eventually required intubation due to worsening of PaO2, drainage of empyema via chest tube, IV fluids, norepinephrine for hypertension, insulin for hyperglycemia, and close monitoring of renal function. Outcome: gradual clinical improvement after 10 days of treatment, extubated on day 8, transferred to general ward on day 11, completed 14 days of IV antibiotics, and follow-up chest CT showed resolution of empyema and consolidation. Now let's look closer to the lungs of a patient who died of pneumonia that showed dramatic and characteristic pathological changes. Consolidation. Affected lungs region, often lobar in Streptococcus pneumonia, are firm, solid, and airless. The lung appears hepatized, red, hepatization, dark red, firm, heavy lobe due to vascular congestion, and intra-alveolar exudate. Gray hepatization, grayish-brown, dry surface as RBCs, breakdown, and fibrin dominate. Pleural involvement, often fibrinous pleuritis with a dull, rough pleural surface. May see also pleural effusion or empyema. We can also see abscesses, cavities, pus-filled spaces, often seen in Klebsiella, Staphylococcus aureus, anaerobe, or aspiration pneumonias. The color normally is spongy, gray or pink. The pink lung normally is replaced by dense red or gray or yellow consolidation areas. Now, summarizing all this, pneumonia requires individualized diagnostics, therapy, ethics. Challenges like resistance persist, but research will help. Thank you for watching. I hope you liked the video. I hope you understood something. I hope you found out something new. If you did, I will gladly make more videos in the future. Have a great day at work.